Hello, it's a pleasure to meet all of you for this ISWOG Virtual Congress. And today I'm going to talk to you about congenital anomalies of the kidney and urinary tract. Before I begin, I would have a declaration that this lecture is a paid sponsorship by Mindray. Congenital anomalies of the kidney and urinary tract are embryonic disorders that occur during development. They are a spectrum of defects involving kidneys, ureters, bladder, and urethra. And as you can see that the development starts as early as 4 weeks and the development of the urinary system continues on to beyond 36 weeks. Now visualizing the normal urinary tract is done by a longitudinal scan to first ensure that the bladder is present, and then we take the posterior section and also a transverse section to visualize both the kidneys. The technique of imaging is to use the probe longitudinally at the back of the spine. Obviously, the fetus is in a spine anterior position, and then you rotate counterclockwise at the lumbar region and gently swivel the probe so that we can see both kidneys, which are identified by the small renal pelvis on both sides. Now, the kidneys are also assessed in two planes to avoid fallacies. The longitudinal or the sagittal plane, you can see the outline of the kidney in the capsule, and the kidney in transverse distinctly brings out the two renal pelvis. The renal length is equal to gestational age in weeks, and a renal length less than 5th centile for gestational age is considered as abnormal, and is over the 95th centile is also considered as large kidneys. Now, as we go down transversely into the pelvis of the fetus, we do find the bladder, and switching on the color tells us the two umbilical arteries which go around the bladder. And bladder can be seen from 10 weeks onwards, and it is always an index of renal function. Bladder filling and emptying can be identified. The Likert is an index of renal function. Now, when we want to assess the renal pelvis, it is always done in the transverse section, and the antero-posterior dimension of the renal pelvis is measured, and between 16 to 27 weeks less than 7 millimeters is normal, and between 28 to 40 weeks less than 10 millimeters is considered normal. It's important to note that coronal measurements should never be done. Now, the kidneys can also be identified in the at 11 to 14 weeks. By doing a coronal section, we can easily identify the renal pelvis. Switching on color Doppler will help us to identify the two renal arteries on both sides. Renal abnormalities can be classified as those with kidney number, where there's a failure of formation of the kidneys and outflow systems. Classical examples here are renal agenesis, which could be unilateral or bilateral. Renal size and morphology abnormalities are renal hypoplasia and dysplasia, and multicystic dysplastic kidneys. Now, when we look at kidney positional abnormalities, we can identify low-placed kidneys, horseshoe kidneys, ectopic kidneys. As we know, the ascent of the kidneys start as early as 6 weeks. Now, outflow abnormalities like PUJ obstruction, ureteroceles, megaureters, vesicoureteric reflux, posturethral valves, and urethral atresias can be recognized in the fetus. Now, let's start with bilateral renal agenesis. The diagnosis can be done at 11 to 14 weeks, but more efficiently at 15 to 16 weeks, where we can see anhydramnios and lack of filling of the bladder. The renal foci are empty, and the adrenal gland is seen lying down on both sides, as you can see here. No renal arteries are seen on color, and we always try to look for associated abnormalities. Unilateral renal agenesis, on the other hand, usually a bladder is present. It can be seen on coronal sections where one renal fossa shows the kidney, the other renal fossa shows the absence of the kidney and the lying down adrenal. And using color Doppler, we'll be able to identify one renal artery, the other renal artery being not present. It's also important to look at two things. When one renal fossa is empty, we look at the abdominal aorta bifurcation angle, which in this case is 44 degrees. We'll talk about it a little bit later. And we also look at the vertebral column and the cardiac evaluation for additional abnormalities. Now, we may believe that having one kidney and the bladder functioning with normal liquor will have a normal outcome. It's important to remember that the other kidney can undergo compensatory hypertrophy in almost 90%. And there is also a prolonged increase in the size and nephron number. This results in stretch-induced glomerular cell activation and nephrotoxicity, and additional CACUT abnormalities can be identified in a number of conditions like vesicouretic reflux, intrauterine growth restriction, and also renal injury can occur, which can later on lead to hypertension, proteinuria, and decline in the glomerular filtration rate. So this systematic study of which consisted of 43 studies and 2,684 cases said when there is unilateral renal agenesis, 32% will have associated CACUT and 20% will have at least one marker of renal injury. And this is important because it's implications for counseling, because we do believe that the patient, we tell the patient one kidney is functioning, everything will be fine later on. We should remember that these children can have problems. In our own series with when there's empty renal fossa out of 299 cases, majority of unilateral renal agenesis, we had crossed few kidneys and horseshoe kidneys, and also bilateral agenesis in 17%. They were isolated in 60%. Associated anomalies were seen in almost 40%. Now, most were diagnosed in the second and third trimester. Now, three signs help us to understand positional and fusion abnormalities. One is an empty renal fossa. Second is abnormal angle of the renal pelvis. And third is abnormal origin and course of renal vessels. When there is a position or fusion abnormality, 42% can be associated with other congenital anomalies and chromosomal abnormalities. Now let's look at pelvic kidney. To identify a pelvic kidney when one kidney is not seen in the right iliac fossa, we make a thorough search elsewhere. And here we can see a color Doppler showing an abdominal aorta which is branching. And this angle, which is called as the abdominal aorta branching angle, is usually less than 55 degrees. Whereas in this patient, where the kidney was identified in the pelvis, the abdominal aorta branching angle was more than 55 degrees. And this tells you that this kidney is occupying the area between the two, the iliac arteries, which helps to, which widens these vessels, thus increasing the angle. Now, kidneys can be found in odd locations, and very rarely we can see kidneys in the thorax. Here's a bilateral thoracic kidneys, as you can see here, and both renal arteries are actually facing upwards instead of facing perpendicularly to the sides. Now, horseshoe kidneys can be a challenge to diagnose, and we do have some ultrasound tips and tricks for identifying horseshoe kidneys. One of them, of course, when you image in the coronal section, you can see a bridging tissue between the two kidneys. And because lower pole fusion is seen in almost 95%, malrotation and also the renal pelvis angle will be altered. What do we mean by renal pelvis angle? Now, here's a transverse section of two normally placed kidneys where both renal pelvis are facing each other. And if you draw a line from the axis of one renal pelvis to the axis of the other renal pelvis, this angle is 164 degrees. Whereas in this case, which is a horseshoe kidney, both renal pelvis are facing downwards and this angle is 86 degrees. So when the renal pelvis angle is less than 140 degrees, it has 100% sensitivity and specificity in the second and third trimester to identify horseshoe kidneys. Now, next we will move on to cystic echogenic kidneys. The terminologies must be understood. One is hypoplastic kidney, which means small kidneys with normal architecture. Second is dysplastic kidneys, which are small kidneys which are echogenic, which may be echogenic with or without cysts. So here is bilateral kidneys which are cystic kidneys, and here is a unilateral multicystic dysplastic kidney, the other kidney being normal. Now here is a kidneys which are echogenic. When I say echogenic kidneys, the renal cortex is brighter than that of the liver, and here the medullary pyramids are seen very clearly, which could be a normal variant. The size of the kidneys could be, echogenic kidneys could be small or large, and there could be hereditary cystic diseases like autosomal dominant or recessive polycystic kidney disease. And lastly, we should also think of congenital nephrotic syndromes. So let's look at one of them. The first presentation here is the presence of a large echogenic kidney, which is bilateral, but the liquor seems to be normal in this case. And when you looked at the maternal kidneys, we found mother also has severe polycystic kidney disease. So it's important that whenever we see enlarged echogenic kidneys in the fetus, we should screen the parents for possible evidence of polycystic disease. In such case, then the diagnosis of autosomal dominant polycystic kidney disease can be arrived at. And of course, there is an opportunity to do molecular testing to identify the gene mutation to help them in the subsequent pregnancies. Now, enlarged echogenic kidneys can be another variant of that is autosomal recessive polycystic kidney disease. It is always bilateral and can be associated with hepatic fibrosis and also oligohydramnios. So here you can see very large cystic kidneys, and at birth these are nothing but cystic dilatation of the renal tubules. So they form tiny microcysts which are there, which can be identified on histopathology. Now the last type of echogenic kidneys which we are going to see is, you can see a normal sized kidney, but very bright and echogenic and it's bilateral. This lady, the first baby died at 12 days due to renal failure. This is the second pregnancy, and it also had a neonatal death. She comes in the third pregnancy at 20 weeks. We found bilateral small echogenic kidneys, and on autopsy, we found the diagnosis was congenital nephrotic syndrome, which is the Finnish type. It is autosomal recessive and can also be identified by molecular techniques. Now, lastly, here you can see an echogenic kidney, but well-preserved medullary pyramids. And when you see the well-preserved medullary pyramids, you can think of this as normal renal architecture, but kidneys are echogenic. The liquor is also normal. So this patient delivered at full term, and the neonatal scan was normal, baby alive and healthy, which means you could have normal appearing echogenic kidneys also. So next we come to cystic renal dysplasia, which can be once we see bilateral renal cystic disease, we look for other systems, and here we can see an encephalocele and there is polydactyly. So presence of an encephalocele, polydactyly and cystic kidneys gives the diagnosis of Meckel-Gruber syndrome. So syndromic association of cystic renal dysplasia should be understood. Now here you can have cystic kidneys because of obstruction. Here you can see a very large bladder, that this patient had a lower urinary tract obstruction, and over a period of time the kidneys became a small dysplastic cysts were formed in the kidney. This obviously means this becomes a non-functioning kidney, and it's called as obstructive dysplasia. And that's the picture after birth. You can see a thick walled bladder in the autopsy specimen. So just to sum up, echogenic kidneys could be normal sized, corticomedullary differentiation, liquor, it could be a normal variant, or if it's normal or small size with or without corticomedullary differentiation, It could be cystic renal dysplasia or nephrotic syndrome, or the kidney could be large size, where if it has associated abnormalities, then we think of syndromic etiology. If there are no associated abnormalities, and if there's preserved or increased corticomedullary differentiation with normal liquor, it could point to autosomal dominant polycystic kidney disease. And if there's loss of corticomedullary differentiation, it could be autosomal recessive polycystic kidney disease or cystic renal dysplasia. Next, we come to fetal obstructive uropathy. Now, the word fetal obstructive uropathy has now changed the term to urinary tract dilatation. It's important to understand that seen in about 1 to 5% of pregnancies. It could be transient physiological in 80%, obstructive pathology, and you could have dilatation of the bladder due to undetermined origin also. Now, dilatation is not always obstruction. Dilatation is a dynamic process. So we need to standardize the nomenclature. We used to diagnose hydronephrosis, pilectasis, pelviectasis, uronephrosis, hydroureteronephrosis, and urinary tract fullness of prominence, but all this has given way to one word called urinary tract dilatation. And you divide the urinary tract dilatation as UTD A1 or A2 and A3. This is an internationally accepted classification for urinary tract dilatation. The criteria used are anterior-posterior diameter of the renal pelvis, extent of the calyceal dilatation, parenchymal abnormalities, bladder and ureteral abnormalities, amniotic fluid volume, and the presence of associated abnormalities. We should always look for presence of associated abnormalities like vertebral, anorectal, cardiac, and others. Now, the UTD classification divides the dilatation into two groups. One is UTD A1, which is called as a low risk group. In this, the renal pelvis dilatation is between 4 to 7 millimeters between 16 to 27 weeks, and 7 to less than 10 millimeters more than 28 weeks. In UTD A2 and A3, you not only have a dilatation beyond 7 millimeters or 10 millimeters at the specific gestational ages, but there is also peripheral calyceal dilatation, and you could have parenchymal thickness, appearance abnormal, ureters abnormal, unexplained oligohydramnios. Any one of these parameters we call it as UTD A2 and A3. Now, what does it mean to us? We mean that when the severity is mild, which is A1, the risk of postnatal pathology is only 11.9%, whereas if it is A2 or A3, then the risk for postnatal pathology is 88.3%. So these patients, many of them would require surgical intervention that needs to be followed up. But once there is a dilatation, we need to know what is the natural history. The natural history is, one is the pelvis dilatation may regress, which usually happens in UTD A1, or it can remain static as happens in A1, or it can progress. Most cases of UTD A2 and A3 will progress. And of course, the timing of progress is difficult to determine. It can suddenly blow up over a few weeks or gradually increase over a period of time. And renal dysplasia occurs in severe cases. Now, the time of presentation is important for prognosticating these cases. In the first trimester, if there is an A2, A3, then certainly it's a poor prognosis. Second trimester, dilatation has a more favorable prognosis, especially if it is UTD A1. And third trimester, higher rates of postnatal confirmed pathology needing treatment. Now, when we talk of obstruction, we can say that the obstruction can happen at several sites. One is at the pelviureteric junction, or the uretrovesical junction, or the lower urinary tract obstruction due to a variety of causes. So let's see some case scenarios. So this patient presented to us at 24 weeks with a unilateral dilatation. It was classified as UTD A2 and 3. At 26 weeks, the calyceal dilatation became bigger. The renal pelvis also became larger. At 28 weeks became even larger, and the bladder was of course normal, liquor was normal. So this was a unilateral pelvic-ureteric junction obstruction, we could also not trace the ureters. Now, in a second case, it's a bilateral uretero-pelvic junction, pelvic-ureteric junction obstruction, 8 millimeters and 11 millimeters. But when it progressed to 32 weeks, you find the right renal pelvis did not progress much, but the left one became very large. So this kind of differential dilatation is fairly common in obstructive pathologies. There are no cysts in the cortex, and Leica is normal. That's very reassuring. Now, it's important also to report these cases correctly, and there are 7 imaging parameters which we use for reporting. One is the anteroposterior renal pelvis diameter, calyceal dilatation, parenchymal thickness, parenchymal appearance, ureters, bladder, and Leica. And in the impression section, we mention the specific UTD category, whether it is UTD A1, A2, or A3, along with suggested management scheme. Ideally, representative images should be provided with the report. Now, from pelvic-ureteric junction, let's move on to uretrovesical junction. The most common reason why uretrovesical junction obstruction is seen is a ureterocele. So here you can see a bladder within a bladder, and almost always when there's a ureterocele, you will see a double moiety, and the upper moiety here is dilated with the lower moiety being normal. So this could also be a simple ureteric orifice in the bladder trigone, or it could be an ectopic ureteric orifice in the bladder neck or the posterior urethra. Now that brings us to lower urinary tract obstruction. The incidence is about 1 in 250 to 1 in 1000. Chronic lower urinary tract obstruction, secondary to many causes, can happen, and post-urethral valves, it's probably one of the most common reasons why we see lower urinary tract obstruction, has an incidence of about 1 in 5,000 to 125,000, and it has a very wide spectrum of prenatal presentation. Other less common differential diagnosis we should consider is anterior urethral valves, urethral atresia, urethral agenesis, and also presacral mass. Now, in the first trimester, we can suspect urinary tract obstruction when the bladder diameter is more than 15 millimeters. In the first trimester, a distended bladder is usually called as a megacystis, and it's between, if it is between 7 to 15 millimeters, we first think of aneuploidy, so do a karyotype, and then if it's more than 15 millimeters, we think of obstruction. And lower urinary tract obstructions can also be due to urethral atresia. So here is a case very early in gestation where there's a very large distended bladder, and you can see a huge distended abdomen, which we typically call as a prune belly syndrome. This baby also had acrania, and on autopsy we find the bladder wall is so markedly thin. It's hugely dilated because the bladder never emptied. Once it starts filling up, it just stretched beyond capacity, and the bladder wall is very, very thin. Now, in the second and third trimester, lower urinary tract obstruction can be one of the common diagnoses we think of is post-urethral valves. Post-urethral valves can be reasonably identified by identifying a dilated post-urethra. Of course, in about 30% of the cases, we will not be able to see this dilated post-urethra, which is otherwise has a keyhole sign. So the major challenge is to differentiate between a post-urethral valve and an urethral agenesis. Now, what happens in a post-urethral valve? The upper tract significantly dilates, and you can have marked hydroureteronephrosis, and sometimes you can have a spontaneous bladder rupture leading to urinary ascites, as you can see here, or one of the calyces can rupture and lead to a paranephric urinoma. In about 3 to 17 cases of 17% of cases of PUE, you will have a paranephric urinoma or a bladder rupture causing ascites. Now, there are various presentations of post-urethral valve. Here's another presentation where you can see a bilateral hydronephrosis at 32 weeks. At 34 weeks, suddenly you can see the bladder hugely distended with the keyhole, which was not noticed earlier. And of course, dilated ureters have started dilating also. So luto presenting as unilateral hydronephrosis, evolving as bilateral over a period of 2 weeks. The next presentation is, here's a patient with 20 weeks. The kidneys look fairly normal. The bladder was also normal. When she came at 29 weeks, both the dilatation of the upper tracts can be seen. The liquor was normal, but the bladder was hugely distended, telling us there's probably a lower urinary tract obstruction. At 31 weeks, you can see a very large bladder and a dilated ureter. And at 33 weeks, she had a sudden rupture of the bladder, causing significant urinary ascites. There was also a rupture of a calyx, causing a paranephric urinoma. So the pressure in that system can give way. It can give way at the calyceal level or at the bladder level. Now the next presentation is that 17 weeks this patient comes to, it looks absolutely normal, and then at about 20 weeks the bladder, 21 weeks the bladder becomes distended. The kidneys are still normal, the upper tracts are not dilated, but at 29 weeks the kidneys are still appearing normal. The bladder alone is distended, but at 33 weeks you can see bilateral hydronephrosis and the ureters are dilated. So, and a keyhole sign is also seen. So what happened is between 20 weeks and 33 weeks, the kidneys were remaining normal for quite some time, and suddenly there was a blowout in the kidneys. So this shows the pressure distribution in the system. The bladder has taken the pressure initially and then transmitted to the kidneys later on. So prominent bladder with incomplete emptying in the second trimester, you should think of obstruction, which can progress later on. The next presentation, of course, is the bladder is normal in this case. At 20 weeks, liquor is normal, but at 28 weeks, the patient presents with still normal kidneys, but massive ascites. And then when you look into the bladder, you can see a small rent in the bladder, dome of the bladder, which is the fluid has gone out and urinary ascites is presenting. So presenting as ascites initially, and later on hydronephrosis can develop, which is also an unusual finding. Now the question in lower urinary tract obstruction is the renal function preserved? Will these kidneys work well long term? Will there be vesico-ureteric reflux? There's severe oligohydramnios. When there is severe oligohydramnios, we know there is compromised renal function and also lung hypoplasia. So the ultrasound prognostication of renal function is one by appearance of the kidneys, where the cortex appears echogenic, or the presence of cortical cysts tells you that the obstructive dysplasia is present. The bladder wall thickness, very markedly thickened bladder wall, and also amniotic fluid volume. And finally, we can look at urinary function by looking at urinary analysis. Now, if you want to do fetal renal function, we can sample the urine. That's a fetal urine sampling. We need to do 3 samples at 48 hours apart, and we look for sodium chloride osmolality, beta-2 microglobulin. And beta-2 microglobulin of less than 6 milligrams per liter had a favorable outcome. More than 6 milligram per liter had an unfavorable outcome. Of course, fetal serum estimation of beta-2 microglobulin can also be done. Now, predicting renal function antenatally, probably the best is amniotic fluid volume, and the appearance of renal cortex at the time of diagnosis of luto has a reasonable sensitivity and specificity. Next is, should we intervene in cases of lower urinary tract obstruction? We intervene when there is renal compromise is just setting in. We do not want to intervene in cases which are severely compromised, because that's not going to benefit the baby in any way. And there are 2 interventions which we can think of. One is vesico-amniotic shunt, and the other is fetal cystoscopic fulguration of posturethral valves. Vesico-amniotic shunt is a double pigtail shunt which is introduced into the fetal bladder, and one end comes to the amniotic cavity, and this there are issues with the shunting, saying that there could be a shunt migration, and of course we know that long-term renal function is unpredictable. The Pluto trial, which was a double-blind randomized control trial, said that shunt improves perinatal survival, but the chances of the baby surviving at normal renal function is very low, irrespective of whether or not whether a psychoamniotic shunt is done. So mostly it should be remembered that shunting is done for neonatal survival, and renal function is something which we may not be able to improve, and a lot more studies need to be done on this. Now here's a patient who had a shunt, migrated shunt, which went into the retracted into the peritoneal cavity, and you can see the shunt inside the bladder, which was retrieved at birth. At 5 years, the patient is having creatinine of 3.4 and is under treatment. Now another alternative method is to do a fetal cystoscopic fulguration of post-urethral valve. We've had experience with a few cases now. A 1 millimeter scope is entered into the cavity, into the bladder, and we identify the posterior urethra, and using a laser, we can identify the posterior urethra and try to fulgurate the valve. Multiple small holes are made in the valve so that we will be able to facilitate the passage more smoothly. That's a laser fiber which is coming through, and small 10 watt or 5 watt laser is more than enough to puncture. Multiple punctures are made, and this was the baby after birth where the punctures are seen and the cystoscopic fulguration was done postnatally. So as far as the we have two methods now, cystoscopy and vesicoamniotic shunting. This retrospective cohort of 111 cases concluded that fetal cystoscopy and vesicoamniotic shunting improve the 6-month survival rate in case of severe luto. Fetal cystoscopy may prevent impairment of renal function in fetuses with post-urethral valves. Of course, larger study is needed to do it because the number in cystoscopy is very, very small. Lastly, I'm going to tell you about fetal therapy for uretrocele. Uretroceles can obstruct and cause severe damage to the kidney. So this is offered to fetuses before fetal viability in order to prevent severe damage. There are 3 methods which have been proposed. One is ultrasound guided percutaneous drainage, laser treatment, and also fetoscopic in utero incision of the uretrocele. So here's a case where we've seen a large uretrocele. We had a case with bilateral uretrocele. So we introduced a 1 millimeter fetoscope, and we are doing a cystoscopic fulguration of the uretrocele itself. Following this, a complete collapse of the uretrocele was seen both sides, and the baby has been delivered. Of course, the obstruction related cystic changes are there in one portion of the kidney. Because it's a double moiety, the other portion of the kidney is functioning well. So I will leave you with some messages. CACUT is a spectrum. Standardized terminology needs to be provided. It can evolve with time. Liker is an index of renal function. Always look for associated abnormalities. Intervention is done in select cases. Long-term outcomes in luto need to be understood while counseling the patient, because we are looking at survival and not at improving renal function. And prenatal counseling, of course, becomes very essential. And some of these disorders have genetic basis. We can offer them genetic testing, which may be useful in subsequent pregnancies. Thank you very much for a patient listening.